pleased to present Dr. Taraneh Shirazian.
Thank you very much for that lovely introduction, Michael. I'm very excited to be here today and to speak with you all on this topic, something that I feel very passionately about. So I'm going to speak on healthcare as a human right, the global crisis affecting women. Oh, and I guess I don't need this microphone, right? Okay. So I feel extremely lucky to be a practicing OBGYN for the past 15 years. My journey in medicine started here and with many of you, and I feel grateful for my time here in the PLME program and the way my education, mentors, and experiences have shaped me. My career since Brown has brought me to the most isolated corners of the globe, where I often wonder if women's voices are ever heard. I have been to the small huts in rural villages in Sierra Leone, Liberia, Kenya, and Guatemala, where women deliver on dirt floors birthed by traditional birth attendants without gloves. I have been to maternity waiting homes across Africa, where pregnant women walk for miles and miles in labor, only to find an abandoned shell of a building without supplies and no health workers. I have argued the emergent need for surgery for patients with ruptured ectopic pregnancies on the precipice of death, and the need for emergent use of an OR for those in need of expedited cesarean section. I have seen pelvic ultrasound machines under lock and key instead of in use, and medical supplies just locked in closed rooms because local physicians don't know how to use them. I have argued with ministers of health about their health priorities and that the HPV vaccine will save women's lives against cervical cancer. I have seen the use of contraception like IUDs require a husband's written formal consent. I've seen women denied basic access to minimal health services in many, many countries, and I have often felt that in the isolated corners of the globe, that I'm the only one who hears them as they whisper their health struggles, pregnancy fears, and their dreams for themselves and their children. It is a serious responsibility to provide medical care in OBGYN nationally and globally. The statistics in maternal and reproductive health have been dire for some time and represent medical issues that need immediate attention both in the United States and around the globe. The US ranks 124th globally in maternal death rates. The WHO in 2023 reported US maternal mortality rate is more than 10 times the rate of other high-income countries, including Australia, Japan, and Spain. There is major causes of maternal death, like embolism, hemorrhage, and mental health conditions. And the amazing thing about all of these causes, or most of these causes, is that they are completely preventable. They are completely preventable with access to safe supplies, healthcare providers, blood, and we'll get to that. Health inequality, discrimination, and mental health failures are key contributors to death in the United States. There is also racial disparity in maternal death here in the United States. Nationally, Black women are 3 times more likely than white women to die from a pregnancy-related cause. In New York City alone, Black women are 8 times more likely than white women to die from a pregnancy-related cause, and nearly 3 times more likely to suffer from severe maternal morbidity. And I live in New York City, so we actually have a local program to combat this, but that's why a lot of our slides are about New York. Maternal death has increased during the COVID-19 pandemic. COVID has further augmented the maternal death rate by 56%. and in 2021, and any decrease in gains globally around the world that had been achieved have now been set back. And very importantly, in 2021, JAMA reported that 45% of women experienced at least one barrier to reproductive health services in 2021. That's up from 10% in 2017. And the reason that's important is because access to safe contraception, to safe abortion care and contraception is the way we lower the maternal death rate. By lowering the pregnancy rate, we lower the maternal death rate. So access to contraception and safe abortion care is key to that decrease. In Kenya and globally, in many countries where we work, the maternal mortality rate is much higher than in the United States and in high-income countries. And here's just a graph depicting the maternal mortality rate. You can see in Kenya, it's 342 per 100,000 live births. And so we actually pick areas of the world where these rates are high to conduct programming to decrease maternal death, to improve access to reproductive health, and to help save women's lives. We were lucky enough that our work has been featured at the American College of OBGYN meeting and in other places, but I wanted to just show you some of our mission and some of our programming in maternal health. So this is a brief video of our work.
Uchungu ikikuja tuende tena. Good. The last one. Push.
Yay, baby boy!
What's the time? 1:46. 1:46. Congratulations, Mom.
Congrats, Mom. All women pregnant everywhere should have access to good quality programming, good quality providers, people that care about them. Oh, you look so good. In many areas of the world, pregnancy and delivery can be very traumatic. A lot of it has to do with infrastructure. You know, women live very far from health centers. Also, their providers are often not trained or not well trained. So the untrained worker at their bedside may not know how to handle a complication well, may not have access to the drugs to address a postpartum hemorrhage, for example. The deaths for women globally are completely preventable. In most areas of the world, if there was access to skilled providers, skilled birth attendants, drugs, medications, blood, women wouldn't die. Saving mothers is really about leveling the playing field. In Kenya, for example, we have a maternal continuum of care program. And the program involves recruiting women from the community to come in for prenatal care. We offer them an ultrasound. We offer them prenatal vitamins as incentives. We also identify any complications at that time. And then we encourage them to deliver at the hospital so that we can make sure that if they have a complication, we can address it. We train the staff, we improve the infrastructure so that they're able to access that point of care.
I think that the work that we do through Saving Mothers is incredibly special. I think it is important for the women that we touch abroad to know that the struggles and the problems that they face are seen and seen outside of their community, and people are trying to help and help their community help them.
Ultimately, what we're trying to do is to change behaviors, to train people on the ground, because we want what we do to be sustainable.
Nilikuwa nimeenda Keringet Clinic, nikakutana na daktari, akanielezea kuhusu Saving Mother project na nikaona itanisaidia. Wakaniambia niende Kapenguria, nikaenda Kapenguria wakanipima. Wakaona watoto kwa tumbo ilikuwa ni twins.
Kwa hivyo utapata mafunzo mengi ukilinganisha na kujifungulia nyumbani ama kutokuhudhuria kliniki. Huwezi jua chochote, ni kama mtu mwenye ako kwa giza. Kwa hivyo utaratibu, hali ya usafi vile vile ni tofauti ukilinganisha na pale hospitalini. Hospitalini kuna usafi wa hali ya juu.
Santiago, where we're based, is a town with a population of about 50,000. There's one medical clinic facility that's free. It's the government facility. And there's no OB. They have generalists there. Traditionally, and in the indigenous communities in Guatemala, childbirth is really done in the home. Comadrona is what they're called. They're midwives, the Mayan traditional birth attendants.
We recognize that women want to have their deliveries attended by comadronas. We know that we're not going to change the culture overnight. So Saving Mothers came up with this 16-week training program where we train the comadronas. We're empowering them. They're becoming respected leaders in the community. To me, this is a very special thing.
The Saving Mothers model is innovate, incubate, and ignite. So we innovate low-cost, high-impact programming on ground. We incubate these programs through field testing, making sure they're community and culturally relevant. And then we ignite by giving these programs to other groups as well to use in their communities, so that the Saving Mothers model is one that not only applies to Guatemala or to Kenya, but can be used for women anywhere in the globe. We are also going to take our global model and apply it here in New York, a local application of the global model of care. Saving Mothers is now 10 years old. We have learned a lot about maternal health and programming in the time that we've been working. But we really need everyone to pitch in and be part of the solution. We need everyone to care about maternal mortality and to actually do more than care, to actually take steps to end maternal mortality. So one of my passions right before the pandemic is actually to take some of what we've learned globally, because we have a lot of years of history with global programming in maternal health, and apply it to New York City, because the statistics in New York and around the country are also very poor, as I sort of already outlined. So we've taken a lot of what we've learned and sort of the perspective and the lens through which we do programming globally and started applying it in our backyard, which for me is New York City. So these are some of the key things that we focus on when we develop programming. We look at health literacy. How can we make this program health literate so that our patients best understand and so that our providers understand? We look at cultural tenets. In New York, we look at other things, which I'm sure many people have heard about a lot in the New York Times and in the press. You know, we're really looking closely at systemic racism. We're looking at implicit bias of healthcare providers, and we're looking at the context of healthcare access and delivery. And actually, we look at a lot of this everywhere in the world, but definitely the US has its own set of challenges. So we've learned a lot from our focus groups, and we've learned a lot from talking to our community health workers around New York and in talking to the women themselves. And we've developed this program that we call the Empower program. And it's two things, and I think it's a dual track, very unique kind of model of programming. We educate and train our frontline workers. In New York, those are the community health workers and the doulas and anyone that's at a woman's bedside, that goes to her home, that provides her with education, that helps her understand resources and referral. Those are our frontline workers. And actually, we train them everywhere in the world, and I'll talk about that a little more. But they are an untapped resource for women, because they often live in the communities with the pregnant women. They are trusted. They are a huge resource that I feel we under-support. So we focus on them. We help them identify at-risk patients. We empower them. with some basic medical education. We help them build trust between both. They already have the trust of the patients, but the trust of the patients and also the trust of the healthcare facilities like the clinics and hospitals. Then the second piece of the dual track program is the Mom's Kit, we call it. And that is a direct to mother resource. So we actually create these educational kits that are filled with health resources like a blood pressure cuff, which we teach underserved mothers in New York how to use. We have a Fitbit where we teach them about, exercise and diet. And then one of the unique pieces of this kit are actually the cards that we include with the kit that help women talk to their doctors, help them be heard, because that's what we were hearing from a lot of pregnant women, that they were being dismissed when they went to the healthcare institutions, to the clinics, the hospitals. No one was listening to them. So our health literacy cards help them articulate their concerns, help them know when there's a problem, and basically helps them navigate the healthcare infrastructure, which quite frankly, probably everyone needs help navigating. It's very hard to go and talk to your doctor, especially if you're not sure what's happening, right? So we really empower them through the help of these health literacy tools. So our community health worker curriculum, it consists of training sessions where we actually teach our community health workers about things like basic physiology of pregnancy, which is always a hit, by the way, because no one really understands how much the pregnant body changes, right, in pregnancy. Blood volume increases by more than 50%. People don't think of pregnancy as an at-risk state. And I think that that is a very important topic that we don't teach enough in the United States, If you go to Africa, there's an African proverb that goes, to be pregnant is to have one foot in the grave. They understand that being pregnant is an at-risk state. But in the US, we don't think of it as an at-risk state. We think of it as a beautiful baby is going to come and, we're going to have baby showers, everything's going to be great. But there are risks involved. So we teach about the risks. We teach about preeclampsia, which is one of the top 5 causes of death in New York. We teach about PE, or pulmonary embolism, blood clot to the lung, which is one of the main causes of death in New York. So we empower our workers. And through distributing the kits, the moms get all the resources. We teach them about each resource, and we focus on these high-risk factors. Here is an example of our Empower Kit. So one of the nice things about this kit, too, is that it's a valuable kit. It costs us roughly $125 to put together. So it is not a cheap kit, right? It's not inexpensive. And we've learned in distributing them that that's actually very important, because they open the kit and the women, when we get feedback from the pregnant women, because we always ask for feedback with everything we do, we're hearing they were amazed because they have like a Fitbit in there. They have like real resources that they know have value. And so in opening the kit and looking at the resources, they think someone cares about them, to put something together that they can use that has value and meaning. So the kits have been very successful. We target the zip codes with the highest rates of maternal death in New York. So we look for the maternal death rates in the city, and then we go to those neighborhoods. And we distribute the kits, and we teach the community health workers in those areas. We've had lots of interviews with our pregnant patients, and we've gotten feedback through use of the kits. And we've heard a lot of things. We've heard that women will take out the blood pressure cuff, they'll use it on themselves, and then they'll take the blood pressure for the whole family. They'll go to their parents' house and take their blood pressure. And so everyone in the whole community is getting a blood pressure, which, by the way, is not specific to New York. That's, again, everywhere in the world we give out something, the whole community is going to use it. So you better make sure that people know how to use it and that you've trained them and they know the purpose and where to go if there's a problem. I think those are the things we think about when we deliver health programming and materials. So the Fitbit allowed them to be more mindful of their health and steps. And, you know, they also said it was, they also told us about things that they didn't know, like the risk of preeclampsia, and that the informational cards were helpful. This is us at a community event, at a community baby shower in the Bronx. Okay, and I'll just say a little bit about our other sites, just as a comparison. Guatemala, which you heard about in the film, also has the highest rate of maternal mortality in Latin America, and we focus on the most at-risk population there, which are the indigenous Mayan women. They often speak dialects. They don't speak Spanish. They speak a Mayan dialect. And in the region where we work, which is the Sololá region of Guatemala, they actually speak a dialect called Sutuhiu. So 75% of maternal deaths in Guatemala are among this group. So that is, again, we serve the groups that are the most at risk. So that's our population. We focus in the Western Highlands, and in our group, only about 2.7% of women receive prenatal care, complete prenatal care. So we also focus globally on getting women access to prenatal care, to services, to reproductive health. It's a big piece of creating programming for saving mothers around the globe. We have a school there where we train traditional birth attendants. So again, a common theme. We train the birth attendants who serve the women at bedside, that help their deliveries, that go into the home. We have now trained them to also provide prenatal care. So when they go into the home, they now are empowered to do things like the blood pressure and to identify women at risk and to help them coordinate with the clinics and the hospitals. And they are a trusted resource for women in the community. So to date, our School of POWHER, you can tell we like the acronym POWHER, but our School of POWHER has graduated over 100 traditional birth attendants. And these birth attendants, in turn, have educated women in their own communities. They've gone out into the other areas of Guatemala and continued to train others. They've continued to serve women. And so we really do believe in graduating people who are well-trained. Saving Mothers in Kenya. In Kenya, we have a maternal continuum of care program. Again, we encourage prenatal visits. And in Kenya, we actually encourage women to come into the clinics and hospitals. We offer them an ultrasound. And you saw it in the video clip, but when we first started doing ultrasounds in Kenya, no one had ever seen an ultrasound before. Can you imagine? No one had ever had an ultrasound. So we were doing pelvic ultrasounds and showing women their babies, their pregnancies, right? And it created just an uproar in the community. And we had women, hundreds of women lining up to do ultrasounds because everyone just couldn't even believe that you could see the developing pregnancy. So we got a lot of ultrasounds donated, and we actually now have trained the providers in how to do ultrasounds. So they offer it at all of the outlying clinics, and they offer it at the hospital. And so everyone gets an early ultrasound. And so that encourages women to come into the clinics and hospitals earlier for dating purposes, to identify issues, and really just to see the developing fetus. And often many want to know the sex. So that, you know, is a draw. Prenatal vitamins are also part of our continuum program, and we also offer IUDs at delivery. So when the woman delivers, we place the IUD if she wants contraception, and that allows a more seamless reproductive health option for her. We serve women at this big, large referral hospital called Kapinguria. It does 7,000 to 8,000 deliveries a year. And in addition to training the local staff and providing resources at the hospital, we train the birth attendants, we do ultrasound training out in the community, and so we create a more sustainable model of care where the community is able to refer into the hospital services are good, and it kind of creates a more sustainable infrastructure for the people in West Pokot, Kenya. these are just some of our outcomes of our work in Kenya. We're extremely busy, as we are at every site, but since 2015, we've done over 500 pro bono surgeries. We've done everything from fistula repair to prolapse repair to fibroids to all kinds of things. Female genital cutting is also practiced in this area of the world, so we've done a lot of repair type surgeries, vaginal repairs as well. We've served thousands of women with GYN, OB, and reproductive health. We've delivered hundreds of IUDs at our satellite clinics, and we now have 3 ultrasounds at the local clinics and 3 full-time sonographers. And the biggest, most exciting thing is we're also building a new maternity ward, or we're helping them build a new maternity ward at the main hospital there because they definitely need it. Okay, I'll get to that in a second. So, in summary, our Saving Mothers work has really taught me about the global needs for women, a lot of the global issues, but a lot also of the hope around being able to create programs that can make a difference, both for us locally and globally. And today, being here at commencement and reunion, I'm reminded of something I feel regularly when providing clinical care and creating programs in women's health, that really the future of healthcare rests with the next generation of people. And they will need to continuously lobby for reproductive rights and advocate for women's health research and funding. Because I do think that all of these issues are at crisis levels. We cannot be complacent in the fight for equal human rights because healthcare currently is not equitable. It is not the same between gender, race, and income, and it is not the same everywhere in the world. It's not even the same in the same city. So we cannot lose sight of what's important. In fact, a survey of almost 500 medical students, and this was just published at our national meeting 3 weeks ago, in a survey of 500 medical students from 32 states that was just presented at the American College of OBGYN meeting, 58% responded that they were unlikely to apply to a single residency program in a state with abortion restrictions. And 77% said that access to abortion would affect where they choose residency. That's 77%. Our new OBGYN trainees recognize that training itself is not equitable across the US. And they won't learn the skills to perform an abortion in many states across the country. That having well-trained OBGYNs in only some states will in turn widen the gap between the states that have access and those that don't, and continue to decrease access for women. And the other thing is that states with higher abortion restrictions already have higher maternal mortality rates. These two go hand in hand. So we never talk about maternal mortality when we talk about abortion, but they go hand in hand. If you don't have access to safe abortion care, you will have higher maternal mortality rates. So this is abortion laws by states, and you can see this is sort of what the concerns are for our new trainees, for our medical students and residents. Where do I start a family? Am I going to get incomplete training? Where's there going to be access to care? Where to train? So this is a map of the US, and you can see how many states have banned it and restricted it and are pending. Very few have legal access to abortion care. So this is very, very problematic for us as a field, and as a country and as a people, access to this care. As physicians, we have an obligation to provide the best care we possibly can for each and every patient. As an OBGYN, a Brown alum, and a mother, I also feel an obligation to advocate, to push the envelope and change the status quo because I have the voice to do so, and all of us do. I feel that obligation every time I learn about a patient's life story, every time I operate, every time I counsel, and whenever I have the opportunity to bring about change in the field, which is pretty much every time someone is listening. Thank you so much for listening today. Thank you so much for having me.